introduce the lovely Reverend Charles Kwaku-Odoi. He's come from Manchester, and he's going to be talking about cultural and religious diversity in the end-of-life care. So I hope you enjoy it.
Good morning, everyone, and thanks for coming along. Fantastic reading about. Thanks very much. Yeah, but thanks for the invitation to the organising team. And obviously, because this is a workshop, we've had some fantastic presentation from Josie, Pauline earlier on this morning, and it's great she's here as well. You know, it's just going to be a conversation and more of a discussion and how, you know, we can all be of help one to another, because sometimes you could go to conferences and, you know, you hear so much and you go away with lots of information, but the things you've been battling with, you know, you've not been able to share them, you've not been able to learn from others. So I have just about 12 slides, and hopefully, you know, we'll have a great time talking and helping one another. So I'm going to talk a bit about culture, a bit about religion, and how that matters. So, yeah, so a bit about myself, then the Caribbean and African Health Network, which is set up in Manchester, then also the Faith Network for Manchester, which I co-chair, then, you know, a few things, and then hopefully we will be there. So a bit about myself. Obviously, I lead an independent Black Pentecostal church, but very strong connections with, you know, mainstream established churches, so whether it's a Methodist, Manchester Diocese, and others. And it's all around making sure that I join in with others in making the least, the lonely, the vulnerable, the voiceless, you know, supported and heard in various places. So I co-chair the Faith Network for Manchester, which is Manchester's Interfaith Forum, and we do all the stuff around interfaith and multi-faith and engagement, and obviously, you know, it's all great for the very diverse communities we all live in. But in the last probably 10 years, I do quite a bit around HIV, and all my work, although in different strands, it's all about how we get into communities. So whether it's the faith communities or the Black, Caribbean, and African communities, and engage. So with HIV, I'm part of, sit on the HIV Prevention England Steering Committee, and then as a faith rep to make sure that I can support with their faith strategies, because HIV prevalence in the UK is in the white gay community and the Black African community. And we know most African people have an affiliation to faith. So whether they belong to a church or a mosque or not, they will have, you know, an affiliation with faith. So how we engage is important. FGM became illegal a few years ago, so went into churches, you know, raising awareness of that, and, you know, women telling me, my grandmother did it, I did it for my daughters, why are you saying we can't do it for our grandchildren? You know, so just taking the difficult topics really into the communities. Modern slavery, once again, going into different African majority churches, talking about how you can spot the signs, and, you know, more important, the support that is available for those who have been victims of modern slavery. And we all know immigration is an issue. So, you know, it's that wider understanding. Domestic violence, obviously being a minister, when you engage with other ministers, if the perpetrator is a key member of the church, then there are issues in reporting them, because then, you know, there's a loss to the congregation and all that. But if we could challenge the ministers and see what the victim is going through and how it impacts on them, then, you know, it changes mindset. And obviously in Greater Manchester with our devolution, health devolution, I've been doing quite a bit of how we reduce health inequalities. Yeah, so I also work, you know, as a freelance consultant, you know, across different things, and, you know, NHSBT talking about organ donation, blood donation, so I'll say a bit about that. And then the Home Office around giving dignity to those who want to return back into their home countries. So the Caribbean and African Health Network, and probably its relevance is about the culture bit. And I think one of the key things, you know, within this workshop, and it was mentioned by Kim earlier on, is all about knowing your communities and who the go-to people are and who you engage with. So in Greater Manchester, we've set up this network on the back of a PhD research into cardiovascular diseases in the Black, African, and Caribbean community. And during consultation, members of the community were saying, we get consulted all the time, nothing happens, what are you going to do with the information? So we came together, 10 of us, and we've set this up. So it's mainly an umbrella organization working with grassroots organization who may not have the capacity for governance or the research, the monetary evaluation for the great and passionate things they get on and they do with on a daily basis. And currently we're looking at 5 streams of work. So cardiovascular cancer, obviously, which is major, mental and emotional health, but all the blood, sickle cell stuff and the donation stuff, and then reproductive and sexual health. And one of the quick wins we've had with this organization is forming a partnership with the Manchester Foundation Trust, which is currently the biggest trust in the UK, with all the hospitals merging in Manchester. And so we have a CAN and MFT partnership and looking at specific things. So with reproductive health, for example, for the last 5 years plus, they don't have a waiting list for black people, waiting, for egg donation. So what we've done is to organize a workshop, bring them along to, leading consultants to talk about what the issues are, and then ask the community, how could you help us? And we had 27 people there, just 3 people knew it was an issue. And within the black community, having your own children is a big thing. So that's why not many people get into fostering and adoption, because there's a cultural thing in there. So I say to people, some of this cultural stuff we talk about, it runs through a whole raft of issues within the wider community. And so sometimes it's about knowing how to have those difficult conversations. Next, a plug here, next Saturday we're having a gala. We're pleased that our mayor is coming along to that. Currently about 250 people, but hopefully we'll get 300 people. So the Faith Network for Manchester, like I said earlier on, obviously faith is important, and so many research and evidence out there about the role of faith, whether in healthcare or people's day-to-day lives and activities. So what we do is seek to give faith groups a voice at various decision-making tables. Obviously, we were quite busy after the attack last May in bringing communities together, that visible presence and faith leaders in different costumes standing and saying, we will not entertain any hatred. And over the last year, we've worked with university students on hate crime and extremism. We also currently working on a faith and health MOU. So it will be a framework, and we're working on this in partnership with the Greater Manchester Health and Social Care Partnership. So Kim's, the organization that Kim works for. So they obviously manage our devolved health budget, and we want to come up with a framework where local CCGs and other health bodies and foundation trusts could work with places of worship and faith groups in general around some of the issues. And building Stronger Britain together, we all know the ongoing work around extremism and counter-terrorism. So yesterday I was in London for the Building Stronger Britain, network event, and we've had some funding for that. So bits of what Faith Network for Manchester does. So now on to our topic. I'll hopefully be brief, and then we can talk a bit more. I think Kim mentioned that the real complexity around faith groups and the diversity in there. So if you take the Christian faith, for example, there will be the Church of England, the Methodist, the Anglican, the Baptist, and then the various faiths. And then you have this all independent churches that are springing up, and different emphasis and different focus. So we don't, and you don't need to beat yourself if you don't understand everything, but I think there are key ways of engaging. So we know there are different traditions. With the Muslim faith, you have the Sunnis, you have the Shias, and all that. And what that brings along is sometimes there will be people you engage with who will say this is faith, but actually it's not faith, it's their culture. Because if you could challenge them a bit more, there is no religious, biblical, or religious scriptural context to that. So people have done things from where they've come from. We know for some people their culture is interwoven with their faith, but so many times people will say this is my faith, or this is a religious thing, when actually they wouldn't find any scriptural context to that. And I think it's something we need to be aware of. Then there's this whole thing around language, especially when we engage in with BME communities who do not have language as, do not have English as their first language. And the stuff that gets missing in translation and interpretation and, lack of, all that, it makes communication really difficult. Then obviously, the whole thing around who is communicating, the messages or conveying whatever messages as professionals you want to carry across. So when Kim was doing her presentation, she was mentioning gatekeepers when it comes to the research and those who are around them. I think when it comes to the religious or faith communities, the ministers, the imams, the leaders are considered gatekeepers. And for you sometimes to have a robust, real engagement and some quick wins, you need to be able to get them on your side. So 4 years ago, when I was approached to do some real work around some scriptural context to HIV, I had to bring 20 faith leaders together and ask them, what are your issues? We want to consider 4 key things. So it's being able to be creative enough to know what the commissioners want and what the outcomes and outputs are versus how the community views all that. So I told them we've been asked to look at testing, treatment, stigma, and discrimination, as well as precautionary behavior. These are the 4 key things we've been asked to look at. What are your issues? Obviously, they all liked the precautionary aspect because that's what the Bible says. And this was African ministers, because that's what the Bible says. So that's a quick read. And then I asked them, what's your issue around testing? Is there any biblical issues around treatment? And then the whole stuff around stigma and discrimination. How do we work along that? And because they engaged, and then we came up with biblical, scriptures within the Pentecostal, setting, and African ministers are very vibrant. Within that context, when we came to the point for, we had to hold 2 summits, they came along. They invited some of their leaders, and then we built on that by going into their churches on Sundays to do the testing after their church service. And we got the pastors to be the first to go for the fingerprint. And that made a massive difference. And for some of us who have done this and keep doing it repeatedly, we know there's no hard to reach community. It's all about who is conveying the message and all that stuff around the scriptural context. So you can see from the graph over there, the Church of England, 20%, but there's also 17% other Christians. And I think sometimes that's where the real challenge is. Because if you're engaging with the Church of England, they have a very robust communication system. They could send one email out and all the parishes will get that. You come into the independent, evangelical, charismatic, Pentecostal churches, they don't have that framework. So how you do that legwork and you engage is where the real challenge is. Right, so culture, most of us, we all know that. But within that is all the stuff around attitudes and beliefs, and the language pops up again, and what are the customs and the rituals. So whether the rituals have a link with people's faith or not, it's still there, how people behave, food, the music they listen to, all that is embedded in there. But I think what is essential within our workshop, and I would love you to take away with, is whilst you might not be an expert in all the religions or the cultures of various BME communities or groups, when you engage in with your service users or your beneficiaries, it's important you ask those questions, or you find out what matters to them. And we all know, that it will vary, but there are ways we could get around that. And then with regards to, end of life, would people rather go to hospice or stay at home? And the evidence we've been told, many BME people are more likely to die in hospital than hospice. All that is there. And then culturally, for most of the African communities or people from African backgrounds, there's this whole thing about the family tree and who is who within the family context. So we've heard of some stories where, and it wasn't in the UK, overseas, a patient dies and the nurse would not inform the wife of the person sat with the, with the spouse. You mentioned spouse bit, because within that culture is the head of the family who needs to be informed. So although this person was a spouse, that message wasn't communicated until the member, the head of the family arrives, and the whole stuff around, the fact that there are occasions where a mother of a dying person doesn't need to be in the hospital. So it's important we understand that there are some family stuff and some cultural things in there. Then obviously within the BME community, all the stuff around whether people are buried or cremated, all those things matter when we looking at the role of culture. I think for most of the work that is done, we all know chaplains are the main spiritual routes into secondary care or sometimes even the communities. And the real challenges within that is the lack of capacity and the limited resources that local chaplains have. So although I was speaking to the lead policy officer for NHS England on chaplains, Paulette, and they were saying chaplains are commissioned locally and they do an equality impact assessment when they've lost a member of staff and they need to replace that, which then straight away means that if nobody leaves the team, then it means that they will never do their equality impact assessment. So you could have, just, for example, in areas that are diverse, just maybe, white male chaplains, and you might not have females, you might not have those who understand all the stuff around sexuality and other underserved population, or even black people within there. And I think having that understanding that there is a limitation within the chaplaincy teams is very important when we're looking after those who are, at their end of life. So then that calls for creativity in how we engage with some of those already established, spiritual care teams, when it comes to people's end of, life. I just thought I'll touch a bit about, organ donation, because it's a real issue, and we all know the lack of, donations from the black community, and we're looking at culture and religion, and when it comes to organ donation, it's a similar thing. So I got invited about 4 weeks ago to spend the morning with an NHS, BT organ donation nurse specialists from across the Northwest, and what they wanted was a bit of help around understanding the Pentecostal thinking and what the issues are around the resurrection and organ donation and all the stuff around the Christian faith. Because they had an issue, in London where they were having conversations with someone who had been stabbed and was, life support in ICU, and the family was considering the organ donation. Then the minister of, that person turns up and then prays with the person and then says, he's going to come back to life in 3 days. So then the family wasn't interested in the organ donation anymore. So it's been an ongoing conversations. So there are longer waiting times. We all know the changes to the law. But some of the conversations I had with them was the fact that there are so many things people say is cultural. I mean, it's religious, which actually is about their culture. And the other thing this brings up is the fact that some of the people within their will or their wishes at the end of life would want to be sent back to their home countries and be buried there. And if we're asking them to donate some organs, if people are not aware how the body is going to look like when it arrives, then they will not be confident in engaging in those conversations, because we all know about organ harvesting and selling and all that, and whichever family members are here are those who will be held responsible when the body gets back. So what I was saying to them is, if people can see the before and after donation and how the body looks like, then they might have a bit more confidence, in having those conversations. Then obviously as a result of what happened in London is who leads the conversation, but also who starts it. So this family was engaged in this conversation, and my challenge to them was, if you had a diverse chaplaincy team, then after this minister had been, you could have invited maybe the black minister on that team to come and have a conversation with this minister, challenge him, and then engage with the family which will bring them back to the position of engaging and having those conversations. So the role of faith is very, very important. And also the other thing worth mentioning, because we can't, so there's lots of research out there how to care for, Jewish people who are end of life, Sikh, Muslim, and you can read all that. But I think one major thing when it comes to the DME community, which, Kim mentioned, Josie mentioned, was the fact that there are suggestions but not much evidence out there. So most African Pentecostals, even at the end of life, will be in a state of denial. It's so difficult to accept because of a strong faith and belief in miracles and the fact that things could just happen, and the story of Lazarus in the Bible, and Jesus' own resurrection and all that. So it's important that whoever you're engaging with, sometimes it's a simple question as, is there anything I can do to help you? How can I improve, your experience at these difficult times? Is there a minister you want us to, call? So that's besides, the chaplaincy team that people have. I mean, most African Pentecostals would want their own minister to come in there. So although you might have, a chaplain who comes there, so long as, he doesn't look or she doesn't look like them, I'm sorry that's the situation, but I'm just being honest and sharing with you so that you have some of these things at the back of your mind. They will view things differently, and sometimes they might want a separate, an enclosed space, and they might end up praying loudly, which I know within the context of stuff, the situation and all that might not be appropriate because of other people's privacy and all that. But I think it's a case of, if you understand the way your clients or your patients or your beneficiaries want things to happen, then you might not be able to, totally please them. But it's a case of making some reasonable adjustments. So, those who would want to pray, and sometimes I've come across people who, I've had prayer chains. So you have people coming in either every 2-3 hours, round the clock. And how you deal with that, you're trying to get on with what you're doing. You have different people coming in who might sometimes ask you the same question or are giving same messages of hope to this family. And how you deal with that is or could be really challenging. And we know across most of the minorities, so whether it's a Sikh, Muslim, Christian, and many others, people want family members around, the person who is coming to the end of their life. And it's about making that space. So whether offering, would you like a drink, tea or coffee and stuff, just simple things. It could, just pull down some barriers and then, get some conversations going. So who leads or who, talks, takes the lead in those conversations are important. I think a few things, borrowing from, because I'm an interfaith practitioner, borrowing from, Islam, where we have the pillars of that faith. I thought a couple of important things for us to leave this workshop with. The first major thing is all about trust and how we build relationship and not just mainly engaging with the community. So trust is something that, is so crucial. If people can trust us, then they can ask the difficult questions, or they can help us in delivering whatever we need to do. So that trust bit. And I think, time and time again, because we all stretch for capacity and resources, we do community engagement and we react to situations. So I know in Manchester, following our attack, there's investment going into the Libyan community. So yesterday I was speaking to the head of counterterrorism at the Home Office and saying, what about the large Nigerian community that's in here? We don't need to wait for something negative to happen before we start engaging. Then there could be Zimbabweans and South Africa. Then, so how we build trust because people are serving, because of the population we serve, is so important. And I think also diversity in our workforce, so whether in the chaplaincy team, in the palliative care team, is so important, because we would come up with policies based on our experiences and our upbringing and our cultures and our backgrounds. And so many at times what the health service hasn't done is seen the workforce as an asset. So all the BME people, wherever you would go, I mean yesterday in the Evening Standard, there are more black, sort of nurses with, across London than non-black. And how we see them as an asset in engaging those communities and having those difficult conversations, is really key. They might not be able to write a report, like Josie will do and her colleagues, but they have some real intelligence that will make your patient experience and survey very important. And then obviously there's the whole need, and I think, Josie mentioned it, around cultural and religious training for professionals. And we know there have been ongoing issues with coroners, when it comes to the Muslim and Jewish community, because of, the quick around quick around time scale and time frame for burying those who are dying, and sometimes obtaining the birth certificate and the investigation. So when it happens to one family, this person has died, but they've had difficulties. The next time someone is in and you are delivering your end of care, package to them and looking after them, they forget about the good things you're doing. They would remember the rough time they had with the last member of family who had passed on, and they wanted to quickly bury in line with their faith. So that comes back to the issue of trust and sometimes explaining to people, why things are delayed. So all the communication aspect is very important. So I think, trust is key. Diversity, let's keep working on that, and some training. And sometimes it might not need to be, large corporate organizations. It might be a member of staff saying, could we have an afternoon lunch where you share with us, where you're coming from, some of the cultural and religious stuff, so that it enhances, people's understanding and knowledge. Right. So since it's a workshop, I have some questions, and I think Josie mentioned this, but also Kim touched on it. How well do we know the population we serve? And, it's so crucial. And because we all here with different experiences, it may be worth sharing what has worked well when it comes to meeting some of the, cultural and religious needs of the people we've served. And then what are some of the challenges so that we can help one another and make our time here worthwhile. So thank you. So any comments, other than that, we get into a nice conversation. Well, there's no waiter or waitress here, so we can't,
I'm interested in what you said about diversity in our workforce, and I don't know if you know, or maybe Josie has got some insights as well into the diversity of the specialist palliative care workforce compared to the general health care workforce. Because I've worked as a doctor in specialist palliative care for over 10 years, and just my personal experience is that I don't see as much diversity in that workforce as in the sort of general healthcare workforce. But I don't know if there's ever been a formal review of that, or
I don't know, but I can see it might make sense from probably a perspective.
Well, I think I would agree with your point. There wouldn't be many people in, palliative care because culturally, people don't like talking about death, and the whole stuff around dying. So, not many Africans would even venture to go in there. I mean, I came over in 2002 after my maths degree, and my initial sort of did 9 years as a healthcare assistant in quite a number of the hospitals across, Manchester. And the first time I told some of my friends and family members, I had to clean someone who was dead, in ICU. They're like, really? And it's sort of strange and all that, because of various myths people have and all that. So unfortunately, there is.
And I wonder if that has an impact then on people feeling that accessing those services, because they don't see people working in those services that are like them, don't feel that it's for them, potentially. That may be a barrier.
It also kind of, there's probably a case in there for sort of greater integration. It's another case of greater integration of palliative and in that it's not a sort of separate thing that just comes in. It's relatively new as well compared to other specialties.
And I mean, when I had the morning with the nurse, organ donation specialist, the nurses across the north, there was no black person among them. And the issue and the challenge is they want to have 40,000 black, donors, blood donors, and then the whole stuff around organ donation. And, I can see it doesn't matter all the conversations we have, until they can begin to make some targeted recruitment and encourage it. And sometimes it's about, I think so much happens, around conversations, just normal conversations, and challenging the stereotypes, but also the myths and, whatever fears people may have,
To answer your question, I think in some sense, it seems to me, we're talking about diversity. Well, I said this morning when I walked in, one of the great things about coming to these conferences, there's never ever a queue for the men's toilet. And I think in specialist house care, I think we talk about diversity, but actually we're not reflective of our serving population from a very basic level, really. But that doesn't stop us, I think as you were saying, Charles, building those relationships. And I work in Stoke-on-Trent, where culturally how the city operates together. Stoke-on-Trent is made of 5 towns, and they've been a city they've been a city for 100 years, and they still operate as 10 towns. And talking to members of the Muslim community and trying to sort of say, well, why is it that you're not engaging in hospice care? Is there something that we're missing? Is there something we can do? And almost universally they said, look, every fear that other members of the community have about end-of-life care and what a hospice is, we also have. So don't necessarily think that it's something extra that no one else believes, which is why we don't have access to care. It's actually a human
Wolf
fear.
Institute report I referred to, just a lot of, they were interviewing Muslim health practitioners and consultants, and they were kind of drawing the parallels, the kind of overlap between everyone's concern, and then there may be nuances and differences, but they're not, it's not a completely separate set of concerns.
We had trouble getting band 5 nurses, and we have a huge population of Filipino nurses in our locality. And so I asked a group of them, have you seen this job? Why aren't you applying? And one of the things was, obviously, the agency that brought them over, they were tied to the NHS, so they could then work for us. But also, more discussions is, well, doesn't your family look after you when you're at end of life? So the whole sort of medicalisation of end of life was just an anathema to them. They just didn't see it as a thing.
I was just wondering perhaps that sometimes the way we train and taught and talk about death is almost a barrier to give palliative care, because we're trained now to be very honest and front-load the patient when talking about death and make them aware they're dying. But in some of these cultures, as you said, people don't accept they're dying. They still believe a miracle can happen. Do we really always have to talk always about dying? But we know they're dying. Can we not just treat them, deal with their pain, deal with their fears, deal with what they're suffering, give support to the family, without talking so much about dying? I think perhaps this is something that professionals have to change their attitude of how we approach palliative care. A lot of these forms that we have to fill in, it's a lot of what do you want when you die? Well, they don't even want to think about dying. So perhaps just finding ways about talking about dying without talking about it. I don't really make sense what I want to say.
I know that there's training for consultants. I'm trying to remember it's in the US or not. I've seen where you ask people how they want to discuss this. I don't know if you guys get any of that, but there's a kind of
Is it called the serious illness conversation?
I'm not sure. But then you start by there's a few questions where you sort of test how much someone wants to know, and then you respect that. And that just seemed, I'm surprised that's not more
think I know what you mean, and I think there is that.
It's Diane Mayer, it's in States, it's the
Yeah,
an
no, I
online.
think there is something being brought over to the UK in certain areas around that.
Because I sort of agree, people, but equally people assume from how someone looks or what your assumptions about them, whether they.
It's that invitation almost, but not that
But even if they,
assumption that people will be happy to.
and even if they don't want to talk about dying, perhaps not stopping offering the care to
Of
those
course,
people
yeah.
and just continuing to
Yeah.
be involved and close and just because that's
Let's chat.
At the other end of the spectrum, have you been interested in any experiences you've had about people who are begging to be allowed to die, who want to end their own lives, or indeed those who actually do commit suicide? Because we know a lot of people with terminal illness, particularly elderly, those with dementia, they will actually end their lives, try and end their lives in very unpleasant ways. So I just wondered what your experience was in that area.
Well, I think from my personal experience, if assisted dying has no place, within my cultural and, sort of religious, and many people would rather ask for help to live on, or their family members who ask for help to live on until the very last minute, rather than, help to die. I mean, I was involved in a case where someone had brought her mum over from Ghana for, procedure, and it was really difficult. Needed a gastro stuff, but she was throwing, she couldn't take in anything and had cancer at a late stage and all that, and it was so difficult. I mean, the first time we were told, she's going to die, the family member said no, and I had to be careful because I was supporting the family, but this is also a hospital that I had gotten a friend who was a gastro consultant involved, so I had to strike that balance, and I had to lean on, towards what the family was saying. Oh, we want you to look. So she had another 2 weeks.
Why did you have to lean towards what the family wanted rather than
Well,
what she wanted? I mean, choosing to stop eating or whatever.
Well, it's a natural thing, as a faith leader, that sometimes you have to support more the family than the professionals.
No, not the professional, the patient.
Well, I mean, the patient couldn't really speak, so it was a family speaking for her, and asking for all the necessary care, and they were willing to pay whatever thousands of pounds it was worth. Although it was at a late stage, we, the gastro consultant involved was a practicing Christian, and so could understand, and so went along to share some personal experience of a medical doctor who was a Christian and, died gracefully and was happy with that sort of whole experience, just to prepare the family. But despite all that, they wanted this person to have all the necessary care to
I know
live.
that's human nature, isn't it? That you're putting off your own grief, aren't you? By not actually, if the patient wants to go, and you're doing everything you can because you don't want to suffer that pain of that person, or to believe that you do everything you could.
So that raises the question about who your responsibility is to, doesn't it?
But it's more complicated, isn't it? If someone has a patient that's expressed that desire.
I mean, you can't,
Thinking with
clearly
advanced
under
care
the
planning.
legislation you can't do anything much anyway, the current legislation, but it does, it sounds like within these sorts of ethnic areas that you're, that you're feeling the responsibility is more to the keeping the family happy with things.
Yeah, but also the other thing in trying to do that at that difficult time was to get the family to respect also the professionals and the fact that this is a professional opinion they're offering, and not necessarily because you're black. And it's sometimes a really difficult thing because that people have had negative experiences from other things, and they carry that baggage, unfortunately. When people are doing their very best. I think you had something to say.
Yeah, I just wonder if we can help sort of have a conversation about end of life care and dying in advance and the sort of booklets which, again, if I've got to try and approach this because within practices, not doctors, again, can approach it and put something into it. Things may change, but again, it may just be something that's a starting point for your awkward conversations.
I read a research piece that said, don't ask what's the matter with you, but what matters to you. And I think that's a really good little sentence to keep hold of.
Which is my
Is that in
priorities
there?
care. It's
Yes.
worded differently, but it's the same.
Yes, yeah.
principle.
Yes.
Just to go back to the question that came over here in terms of what can we do to help someone who does express the wish to die? And I think for me, the key element to good spiritual care, good religious care, cultural care, is to be able to take time and to, I think, to acknowledge that we all come with our own set of beliefs through life, whether those are religious, whether those are spiritual, whether those are cultural, and that our first reaction when somebody broaches that may be to inwardly recoil, and I think to be aware of what it is that we bring into a situation, and to be able to put those to one side, and to then take the time to listen and explore with the person why is it that they're wanting to take that option? What is it? What are their concerns and fears and worries? And certainly I found in my experience working with our medical team that if those concerns are around pain and loss of control and loss of dignity, then our medical team is able to engage in that conversation and say, well, these are the things that we can currently do. And yet, if the person still says, well, actually, if this is the option I want to take, then we do have to say, the law at the moment, as it stands, means that we cannot facilitate that, we cannot hasten it. And we've had several patients who have taken what they were euphemistically referred to as the Swiss option. And I think that therefore one of the ongoing aspects of care that we provide to them and provide to their family is then not to judge them on that decision and not to lessen the care that we give to them. Because I think if I were to put it in my camp, if I felt that no matter what decision I made toward the end of my life, the level of care and the depth of care that I received remained the same, that would be quite a healing occurrence.
I've been palliative care and have end-of-life conversations a lot, and suicide or ending life comes up all the time. And in my experience, it's not that people really want to die, but the majority of the time it's that they don't want to carry on with the life that they're living at that moment. And if we can improve that, then often they will choose to live out the rest of their days in a better way. The trick is getting it right, which sometimes we don't do.
I think there has been quite a lot of evidence in the Netherlands that if people are, say, apply for end of life assisted dying, then they are approved, but many of them, I don't know, it's about half, will never go through with that. And they actually have a much better quality of life because they have that reassurance that if things do get too bad, they can actually end it.
As you said before, my experiences of patients in the BAME communities has been very opposite to assisted dying, but very much wanting to access treatments right through to the end of their life and prolong life as long as possible. And some of the most difficult situations I've been in is when maybe patients and families are requesting a treatment that isn't deemed medically appropriate in that it wouldn't be felt to be of overall benefit, such as artificial nutrition in the dying cancer patient or cardiac pulmonary resuscitation in a dying patient. And I just wondered if you had any experiences of helping support families and what has been helpful when there's been those differences of opinion between families and patients versus healthcare professionals in those areas.
Well, I haven't had that many, but I have, other minister colleagues who, have dealt with some of that. I think from the African sort of Pentecostal perspective, it's more of, we need to get more people to pray. We need to, sort of have more prayer sessions and, that active faith and hope and trust that, a miracle will, come along or something will happen. And I think that's been much of, what I have seen over time. I think there has been issues, for example, in Manchester, and babies that are born premature and been obviously told that they're not going to make it, and some of the issues has been around, once again, mothers wanting their pastors to come along and pray, and people come in and keep praying, and so sometimes it's just about providing that space, for people, and it's worth mentioning that some have pulled through. So when people hear of some who have pulled through when they've been told they can't survive, then they also want to carry on. There was a case that the family decided to sue the hospital because mother who was elderly went in for a checkup and was kept in hospital because they discovered she had some form of cancer, and then but at a very latter stage, and they were wondering why it had not been discovered on previous visits to the hospital. So then, within a couple of days, the family was told there's nothing that could be done for this, Caribbean lady. But then her daughter and son decided that we're not going to give up on our mom. So what they decided to run shifts in looking after the mom, and they were bringing in, porridge in the morning and some mashed vegetables, and they were feeding mom with a syringe, because they had seen her given cereal when she's nailed by mouth and cannot eat, and they had issues with that. They stopped taking her ops, and no chats were kept about fluid intake and output. So for 2.5 weeks, they fed mom with syringe, and all that. And then the first thing mom asked when she could speak was, "Could you brush my teeth?" And then they had to start helping her to walk. And during these 2.5 weeks, the medical team on the ward did not know all this was happening. So when the lady requested, could my mom be discharged, the doctor said, oh, if she could walk up 13 stairs, then we could do that. And she told them, yeah, she will do that. And she did that. And they were quite surprised, but for such, an experience, the next time they access service, they go along with the baggage. People in the community get to know, oh, if you go into the hospital and you're black, we looked after and all that. And, and it's sometimes these are the things that creates real issues for genuine people who are doing their work and have the best of intention. One negative experience,
I lead a spiritual care team in Stoke in hospice, and I think for us, again going back to said earlier, what works for us is about taking time with the family to explain and to talk about the if families continue to feed when somebody is in danger of aspiration, to sort of explain what happened, because we all have that great human desire, don't we, that when we're ill, somebody will care for us and feed us, and so therefore there is that link with us. And we often say in our organisation that one of the problems with the do not attempt to resuscitate things is that people watch Holby City, where you have a heart attack, 5 minutes later you're in bed eating cake. and I think it is that sort of that education, that gentle conversation with people. And I suppose at the end of the day saying that legally this is the decision of the medical team. And I think we have to be gentle but clear that actually our medical teams operate within legal clinical guidelines, and therefore those are the ones we have to bear in mind to protect our patients and protect ourselves. And that's not always easy to hear.
I can see that the work that you're doing is kind of, because we're talking about doing that with individual patients, which is there's so many dynamics in individual situations, whereas the work that you're doing is really, really important. You're talking about engaging nurses from the same kind of communities and that, I guess it seems to me that's the way kind of that trust is going to be built, and that situation in front of you, you work individually, but how difficult that is, and to have this other work going on is difficult. When I was on a recent study, I was very privileged to go to several countries and interview people, healthcare organisations that were implementing advanced care planning. And in Australia and New Zealand in particular, there was a very big issue with Southeast Asian communities where the same they would not let someone die, and they actually have things like these gloves to stop patients pulling out their feeding tubes, and the moral distress of healthcare providers, but it was really challenging situations, and I don't see how that changes except with larger movements.
I think, as the gentleman said early on, it's about maybe we having a mindset that, although it's a patient that, you have a patient who has at the end of their life and you're caring for them, the engagement is with the family and not just a person, especially for BAM communities where family is always family. Then how you engage and dialogue with them around some of those difficult conversations. And obviously, if you have palliative, if you have chaplaincies, whether in the community setting or in the hospital, it's about how they can have those conversations with those families and the faiths they belong to, and with the organ donation, the organ specialist, what we've said was, could we have a Northwest conference where we bring black ministers together, and some of us who believe in organ donation and don't see why you wouldn't go to heaven if your liver is given or your kidney is given to others. Could we have those sort of conversation? And I think that's how we can begin to build trust, and people can see what before and after looks like, and what the evidence is, and the number of people who are on the waiting list, and how that is disproportionate. I think if we could find ways of convey the message and explaining the real issues and the challenges people are facing, it could begin to make some difference. So I think we have a bit more time, and maybe it might be worth getting some experiences around how people have built trust with, you know, whether patients and their families, or, you know, or generally is their way your organization or your team, you know, works, is their approach, and how do you ensure that, you know, those you look after trust you a bit more? Any experiences?
Just curious, the fourth item, training. How much involvement do you have with undergraduate medical background training, and also with GP registrars working in the community at the beginning of their careers?
Well, I mean, we in Manchester, we're hoping that the Caribbean African Health Network, our partnership with Manchester Foundation Trust, will begin to address some of that. Because, I mean, unfortunately, you might not always find qualified, you know, lecturers, senior lecturers who understand what happens in community from those groups and those underserved population. And so it's about sometimes how you think outside the box. So for example, I mean, the stuff that I do with the Home Office came about as a result of one of their staff. I mean, it was a modern slavery event, and someone saying that I was going into churches, and then this person came to sit in on the presentation, and then we developed this, which was outside their commissioning framework. So maybe it's something we need to take back for medical students, because I mean, I was on a call with the Associate Director for Inclusion within MFT, you know, 2 days ago, and she was saying, we're looking at our midwifery students that are coming through, and there isn't diversity in there, so we know in a couple of years' time, we're going to have issues. So can we start a conversation now? So I think there's a real need for some proactive doing things slightly differently. And, you know, I mean, from my experience, most of the engagement at community level or changing behaviors, it doesn't require lots of resources. But the situation we found ourselves in, sometimes because of all the monitoring and evaluation stuff, is that usually government and local authority will commission big organizations that have the credibility and they can hold to account, or they can sue, or whatever is the issue. And then by the time they come to the communities that are really affected or where the work needs to be done, those community groups will receive crumbs. So there's been mistrust. So you take, for example, sickle cell, and the fact that it affects, you know, Black, Caribbean, and Africans. And you know, usually it's either the commissioning is across the Northwest or nationally, and people feel it's not for me. And then HSBT will commission a consultancy company who has a contract with, you know, who is one of the lots within the, you know, government communication service and whatever. And then by the time they commission the people who do the recruitment and the awareness on the ground, you know, that cake is left with just, you know, a little bit of the icing. And so then there's a real issue. And I think for some of us, those are the difficult conversations we have in saying there's no how to reach groups. You know, if we know we're going to have issues, you know, down the line, then how do we do things differently? We know there are issues around care for people with sickle cell who are in crisis, because once again, it's not taught, whether in nursing profession, and you know, we know paramedics who've had issues they've attended and they don't really know what to do because it wasn't part of their training. So I think it's that whole system approach we need to develop. And you know, if this is a group that, you know, is fast growing within our population and they are currently underserved, how do we come up with creative approaches to make sure that, you know, we can use just a little bit of resource, but to, you know, tick quite a number of boxes.
It seems to me that there's a question about that broader realm of what medical training is about. Medical training sort of is general, and then it becomes specialist as one progresses. And although we talk about healthcare being holistic, it isn't really. You know, because there is so much demand on our clinical practitioners' times that they, you know, they have to focus on particular things. And so I think there is a general question to be asked about how we train people in healthcare. Do we really train them holistically? Is that possible to train them holistically? And I think, you know, the committee that you were talking about, Paulette Johnson, who's part of the person who helps run the NHS England's network for spiritual, pastoral and religious care in health. And that's part of their agenda, is about saying, okay, how do we engage with caregivers at the very root to help them gain the confidence to be able to address these issues? Because, you know, there are, certainly in the London area where I came from, I worked in West London, and there were 270 different nationalities in our catchment area with 300 different languages. Now, there are few and far between would there be any healthcare professional would say, I know everything about all of them. So there's something about saying, okay, can I at least develop the confidence to be able to address issues that matter with the person who's sitting in front of them? And it seems to me that's part of what our basic training should be, not to feel scared, not to feel as though I'm going to say the wrong thing and offend you. Because in my experience, no one has ever been offended by the question, how can I help you? Whereas we do get offended when somebody presumes to know what I need, what I want, how I should act, what I believe. And so for me, I think it goes back to that root thing about, you know, what is it that we're here to do? And it's about, what can I do to help you? What, as you were saying, Charles, what's of importance to you?
And I think coming back to the question that you raised about talking about dying without talking about dying itself, you know, so I'm just thinking maybe a creative, clever way, you know, when we know what is happening to a person is, you know, could you tell me a bit more about your faith? What matters to you? How do you look after people generally? When, say, it could be that a conversation with a family, so that you know how to handle the patient a bit more. Can you tell me, you know, what's involved, or when someone is dying and all that? You know, will music make any difference to them? Especially when we're talking about people with dementia earlier on. You know, what are some of those things? How do we hold those conversations? And it might inform us, because, like you were saying, you know, 270 nationalities, you can't, and nobody will expect you to be an expert on every single nationality. But if you know the person you're dealing with, so whether it's the nurse, palliative nurse, who starts that comment, oh, could you just tell me a bit about your culture, your background, how you do things back in your home country? It's just the beginning of building some form of trust, and people know, oh, you know, they're interested in listening to me, so I can share a bit more, and that might make a lot of difference.
Can I just say, I'm a GP and I qualified not so many years ago, so I've been through the whole training process. So I'm just thinking, all sitting in all these trainings, in sessions throughout the training process, it's all general themes, like you learn about equality and diversity training and treat people with respect. So it's all nice, very nice words. And then you go through all these teaching sessions, and then actually you're a qualified GP and you're on call, and you're called by this family to this home to do a home visit, and then you go and face this patient who is dying, and nobody actually prepared you to how to deal with that real situation, because from all the nice principles that we all are taught about, to actually be there and have that difficult conversation and have that pressure, but perhaps you'll have another list of other 5 visits to do, and have all that time to spend and listen, and it's really, really difficult. So I think perhaps if part of our training will be offered more involvement in practical ways of going, I don't know, visiting a church or speaking to these people in community, learning this way rather than just being left and have all these nice talks, but actually not the practical side of things. But because it's how we all say, it's when you're a duty doctor and you don't know what to do because actually you've not been in that situation. You know the principles, you don't know what to do.
And also people behave differently in crisis, don't they? So there's all of that going on. So it's the psychological support of the other people in the room that you're mindful of. So it's in that crisis situation, it's difficult then to have meaningful conversation. So if we brought the conversation further along the food chain really before it actually becomes a crisis thing, so people are prepared a bit better and understand a bit more, you know. Certainly in our hospice we have a day hospice, so we might get to know our patients further along their disease journey than when they arrive for us for the last 2 weeks. So there's opportunities there to have those conversations to prepare them, so by the time they're speaking to our consultants and doctors when they arrive, they're further along in their thinking.
I mean, one of the things that has happened in the counter-terrorism and extremism sector, you know, obviously since 9/11, is more engagement and, you know, visit my mosque day and all those stuff because of the, you know, issues that have come in and time again. Many perpetrators are more likely to come from a Muslim, you know, background, and, you know, I say that as not one that stigmatizes and, you know, but, you know, what assets do we have in our community? You know, could we have a conversation, you know, is there a day you could bring the imam over? Could you tell us, you know, about death and dying and, you know, how people would expect to be looked after? And having those conversations before the issues happen, you know, might be very helpful.
In our hospice, we have student doctors and they spend time with us in the social work department, and it's useful because they are from other cultures, and I have student social workers who are from other cultures, and we just share information. So, you know, they learn from us as much as we learn from them, and I think that's a good way. You know, it's always part of an ongoing training, and to be in a learning environment where it's okay to make mistakes, and to ask really the communication side. But as a hospice, you know, we'd have anybody come to see us who wanted to, you know, find out what we're doing. That'd be fine.
It comes back to what you said, conversations.
Yeah.
People talk and learn from each other.
Yeah.
So that's how humanity moves on, isn't it?
Yes.
Just with those kinds of sharing opportunities to develop our understanding. It is just having the conversations and sharing experience.
And it will depend on the local community. You know, if you've only got one prominent ethnic group, it may be much easier than if you've got 200.
Yeah, in Cheshire East, I'm the ethnic minority, I have to say, but some parts of Bullington that if you don't marry your brother, you're
And I think part of it is about the reality of where we are. You know, religion is only asked on the census in 2001 for the first time. Since 1850, 1851 was the census starts. Religion is not asked until 2001. So we're still on a new journey. And so I don't think we should, absolutely, we aspire to, you know, if I can misappropriate a Zen phrase, what we do is perfect, and what we're trying to do is improve that. Because actually we do our best, and I think one of the other things, and I think what I always try and teach to our medical team is we do the best we can where we are with the resources we have and the time available. So we don't beat ourselves up over it. Absolutely, we have those great aspirations, but we don't use them to beat ourselves over the head because our heart is racing ahead of what's possible at that time.
I was only going to say, if I was doing interviews, one of the things that stuck with me, a senior manager, lovely, such a lovely guy, and he was saying it seemed ridiculous to him that medics didn't get much end-of-life training, if any, and what he said was most people are learning on the job, and if they're learning from people that don't know, that are doing it badly, that's not a good situation. So I guess I'm saying that in that I think, you know, it's the balance, isn't it? As something becomes more embedded, it becomes part of the institution. If actually a lot of things still happen in training, but there's a kind of a difficulty then in implementing that when you've got other pressures or lack of support when you're actually doing it in practice. There's a gap.
You can
And it's
learn
filling
that
that gap.
gap. You can learn from if it's not done the way you'd like it to.
You
can learn as
can- it
much
can
from
inspire
when things
you,
go
can't it?
wrong as you can when things go right. So if you know,
Well,
example when
that's
you were
what,
at
to be
home.
honest, I'm here, because what happens is once you're on the job and you identify that actually you don't know how to deal with the or you could have done a lot better in a certain situation, then you become very proactive and build your knowledge and build your experience and ask more. But I just wish perhaps part of the training that you were prepared more for that kind of, we're only focused on how to treat diseases, make diagnosis, give medication. Not so much about this cultural diversity, like from practical point of view.
You've highlighted a training issue though, haven't you? That you could feed back and say, you know, we need more on this.
And that's the first step, isn't it? I mean, we're all here because we realise this is an issue. So, you know, in previous generations, that might not have even been considered an issue.
And I think one of the great opportunities is we have, you know, which the partnership could find a way of, you know, ongoing conversations even beyond today. And sometimes when you travel around, people are doing great stuff, but nobody knows it. And we don't share a lot. And unfortunately, our media will only carry out stuff that is negative and, you know, all the bad. So we need to find real opportunities to share best practice and the good news stories, and so whether it's a Facebook, you know, closed group or whatever, because I'm sure, you know, what our friend has shared from Stoke, and you know, even the way he's communicated how he leads the team, and you know, all that, and there are links to medical student. I'm sure if others could adopt that as well, you know, we will improve experiences of the people we look after. So we need to find ways of sharing, you know, the good news and all the great stuff we're doing.
And it's a two-way process, isn't it, like you said, because if I'm going to this, I've got medical students or GPs with me, I may well think, I'll ring you up next week and say, could you take them for a session and do it, and then it works. You, that's it, you know, that you could do to other colleagues, and say, for the nurses, I'm going to get, there you go, do it. Any form.
And I think the example from the hospice where you have you know, medical students from different cultures, so that there will be nothing wrong in other hospitals, you know, when you are taking on students to ask, you know, for people from diverse backgrounds, because it's all the conversation and the sharing and the learning, you know, as well. Yeah.
It was a teaching each other because one of the doctors had made an assumption that the family would care, and we said, well, what if someone's got no family? What if, you know, they've fallen out with their family? This happens, you know, people have had a lifetime of struggle. Things don't get magically better when you're near the end of your life. They tend to heighten the problems. So, you know, we're working with people who are isolated or have been homeless. You know, it links to all the other workshops we've got today. The social problems of people.
So I'm thinking about a case that was described to me. It was Aboriginal family patient and family, and it was what you just said, where the patient was rejecting, didn't want the elders to speak for her, was rejecting this, there was lots of kind of conflict, and it was a very difficult situation for professionals. Have you been in situations like that, where you've got a kind of traditional structure, but you've got some members that are saying, I don't want to do this in accordance with kind of... No, it's not something. I'll try to make things more complex,
Well,
but I think it happens.
Well, yeah, I mean, and in saying that, I'm aware currently, you know, second generation, you know, African, you know, children. I mean, some are growing up and they are saying to the elderly ones, you know, your view of life and your preferences and all that, is no longer relevant, and so some internal tensions.
Yeah.
So I can see, where you're coming from, and it's a real challenge, So yeah, within some of those BAME communities, there are real issues, and then sometimes even within the faith groups as well, real tensions, and it's not always easy when some of us are talking about sexuality and all that, because there are ongoing divisions within the different faith groups and all that. So it's a case of we being aware that it's not all homogeneous within the BAME community, and yeah. So I remember in 2011 census, they had a Somali worker for within Manchester, and I'm saying, you don't have an African worker and you have a Somali worker. Is it just because they've created issues in the past? So the other 51 or so African countries or people from there who live within Europe, does it mean they don't matter? Then you must be sitting at a time bomb. In no time, people will feel, oh, the resources get diverted. So I think it's, like the gentleman said, it's been knowing that we're doing something for the common good of the population we seek to serve, that's a faith word, that we seek to serve, and then making best use of the resources we have, and doing our optimal best to get people feel included, involved, valued, listened to, and all those simple things. I think that would go a long way to make a real difference. I mean, when we engage with people around recruitment, for example, for some of the young people growing up culturally, you don't speak back to an elderly person. So we're having a conversation with Northwest Ambulance, and we say, you can have some black people coming in, they might speak well, but they don't maintain eye contact. And that's because it's a sign of lack of respect when you look at people. So they've come to this authority figure. So if those on the interview panels know that, then they will understand where the person is coming from, and then they will judge them more on their ability and competence rather than some of those stuff. And yeah, so this cultural, religious stuff is ongoing. But I think in our current context, where there's legislation for GPs to ask whether someone is of a particular sexuality and all that, maybe we collectively need to be going beyond that and also asking people what matters to them. Do you belong to a faith group? Is there anyone you want us to involve in your care? And all those simple at the early stages, so that it improves the experience of the people we're looking after.